Design a successful facilitated model of support that addresses the unique cultural, technical, personal, financial, and environmental issues that these practices face, with particular attention to identifying and eliminating processes that add little or no value. And I think the regional health IT extension centers are a good start. Promote reimbursement models that account for direct and indirect costs of practice evolution, align incentives across the continuum of healthcare system, emphasize quality of services rather than promote just volume, and support patient engagement in their own care with guidance from their trusted healthcare team. And then finally, recognize that private small practices are small American businesses. However, unlike other small companies, they are essentially powerless to set prices, are burdened with layers of administrative requirements that add little to the value of their services, and face considerable uncertainty about their viability as businesses. Yet these physicians provide the majority of ambulatory care services in the United States, and many would not return to the larger groups in which they previously practiced, despite the daily challenges to their existence. They are resilient, resourceful, and committed individuals and teams, all attributes that are necessary, but unfortunately probably not sufficient to assure successful transformation to a technology-enabled, patient-centered model of care. Let me close with an example of what success might look like. It may be too early to tell for some or the majority of small practices, but let me tell you about one solo physician in rural Vermont. He patched together a quilt of technology in support of his practice. He picked affordable, though sometimes incompatible, technology in response to the perceived needs of his patient population and his desire to be innovative. He implemented an EHR before there was a certification process, added online patient experience assessments, subscribed to a patient portal for secure email and web visits, tried to do registries on his own by querying his practice management system in EHR, implemented a separate e-prescribing program, and implemented in-office laboratory tests, and started a standalone patient counseling tracking program to help with warfarin management. Now this physician is participating in Vermont's Blueprint for Health. He's receiving financial support to implement a CCHIT certified EHR. He's getting technical support and will receive reimbursement tied to his recognition as a patient-centered medical home. Vermont is also setting up community care teams to help support the goals of the program with respect to care coordination, patient education, and behavioral health. But interestingly, one of his biggest challenges is how to duplicate all of the functionality he achieved in these separate, disparate systems with this one system he's now implementing. In closing, I provided through in your binder books, you have a DVD that profiles 7 of the practices we worked with around the country. We interviewed the physicians, their staff, the patients, and tried to capture the perspective of small practices in America. I want to thank you for the time, and I look forward to the questions you may have. Thank you.
Thanks, Michael. So we purposely started off with the personal challenges so that we could tell you how we're going to fix them all with the remaining panelists.
Thanks for teeing that up. I can give you some additional data about people that work in small practices. The IT support is invariably the brother-in-law who supports their system, but he has a real job during the day, and he does this on nights and weekends. And you've seen that, right? I'm going to give you a little bit different perspective. I'm going to talk about EHR implementation in small physician practices from the perspective of a functioning health information exchange. That's the twist that we're coming at this with. To do that, I have to say a little bit about HealthBridge. Some of this is in your packet. HealthBridge is one of the largest and most advanced regional health information exchanges in the nation. We operate in Ohio, Indiana, and Kentucky, which is important, and I'll get to later. More than 90% of the health systems, hospitals, public health departments, and physicians in our primary operating area, which is essentially a 50-mile radius around the city of Cincinnati, use HealthBridge services. In a typical month, we'll deliver over 3 million clinical results of many different types to over 5,200 unique physicians. And thousands of other people in their offices use the data. That's just the physicians. Our services assist a wide range of users. I'm really focusing on just the physicians in this discussion. HealthBridge is also one of the most financially successful health information exchanges, being very much self-sustaining. The reason for that is only 3% of our revenue historically has come from grants. 97% has come from paying customers that vote with their dollars for value that they believe they're receiving. We estimate in a very rough way that we reduce healthcare costs in our community by at least $20 million a year, including our operating expenses. Because of our success, I'd like to explain some of our observations of how physicians in small practices can really be impacted by an operating health information exchange. We're particularly proud that nearly 70% of the physicians in our service area currently use either an electronic health record or an EMR Lite. EMR Lite is the clinical messaging system that we deliver results to in an automatic way. We do that for the physicians across the community for no additional cost other than they have to have a PC and a connection to the internet. I'm very careful not to say that it's free because they stand up and say, where's my PC, where's my connection to the internet? Anyway, most of the physician practices that we do bring up on the clinical messaging system eventually move to an EMR. So clinical messaging that they can use in a variety of ways, including getting the results electronically and having them auto-print and having their staff deal with the electronic portions, then they end up, because of lifestyle issues, which I suspect would be very important to your physicians, when they understand that they can get to their results at home in a secure way over the internet, all of a sudden it's important to them to be able to use the system and to move forward with it. Then they get more and more engaged and see what they can do with it. They begin using workflow components that are part of the EMR Lite within the office, and then they take the step and say, okay, let's look at an EMR, and they talk to us about how to do that. Very few of the small practices are ready to go from a paper-based system all the way to a full EMR in one step. We see that an incremental, stepwise approach to health information technology really makes a big difference for the small practices in particular. A health information exchange can also increase the uptake of electronic health records and make a strong case for their adoption. For example, in the small practices, we are able to take them from the EMR Lite frequently with years of historical data and get them to, in their adoption of the EMR, to actually open up that EMR for the first time and have their, and have their patients already in it and have years of historical data in the EMR when they bring it up. So rather than having it turned on and having it emptying and having that feeling of, oh, we have a lot of work to do, they can go very quickly from the starting point that we launched them on into the EMR. Let me give you a little story to kind of characterize some of what we're seeing out of some of the small practices. We had a physician in a two-physician practice talking to a group about local quality control issues. We're working with the Barbara Wood Johnson folks on advanced medical home, and he was engaged in that. And somebody asked him how he was doing with his electronic health record, and he fortuitously had just had a call he just called a patient to tell her that her mammogram results were okay. And the patient was stunned. She said, wait a minute, I'm just walking out of the building where I had the mammogram. How did you do that? Well, the answer was that we had HealthBridge. He had HealthBridge. It's connected up. One connection to HealthBridge brings the results from 26, 28, depending on how you count, different hospitals, the national labs, and others, straight into his EMR. One connection to us gets all of that connectivity across the community, something that very few of the individual practices would really be able to muster on their own. So it makes a big difference. He also went on to explain that this happens a lot, that patients are frequently very surprised by how quickly he's able to get to his results. In addition to this, we've been able to drive standards across the community and give the physicians tips about how to acquire an electronic health record and how to negotiate their contract to implement it. That typically has to do with negotiating the inbound and outbound interfaces before you actually ink the contract. Anyway, just to conclude, the task before us is certainly huge. Some would say it's impossible. I think, like many other things we've seen in life, that an 80-20 rule will apply here, and this is really one of the key points. We believe that we can get to 80% of what you can do with a full-blown electronic health record for 20% of effort and probably less than 20% of the cost using an EMR-light approach. Data won't be thrown away. We'll be able to migrate that into a full EMR when you get there. It's something that the customers can drive. The whole notion of being customer-driven, and they get to make the choice of what EMR and when to move to it is also very significant. We also think that operational HIEs can serve as just hubs of experience with the health extension centers, and that's a big part of how we will certainly approach making it work. Anyway, market-driven, having the customers really lead the process, and giving the physicians an array of choices to be able to move through the sequence and helping them at every step along the way has really been our approach. Thank you.
Thanks, Micky.
Going down. Good morning. There we go. Thanks for the opportunity to come and speak to you today. In your packets, you've got a copy of an article that Farzad Mostashari and I co-wrote that was in Health Affairs that describes a lot of, sort of the nuts and bolts of the Mass eHealth Collaborative, how many physicians, what we did, all of that. So I won't go over all of that in the short time that I have here because I very much want to get to the question and answer and so that I can, tune my comments to what you're most interested in. But the Mass eHealth Collaborative, just in two sentences, we've implemented 600 physicians roughly on electronic health records from 4 vendor systems. We're currently working on, we've launched 3 health information exchanges in 3 communities and have a quality data center that now extracts quality information out of all those deployed electronic health records and develops 20 core measures that we provide in reports back to physicians via web-based reports. We are now implementing another 300 physicians on electronic health records for John Halamka at Beth Israel Deaconess. Are also implementing EHRs in a pilot project in California as well. So have had a lot of experience now in electronic health records, health information exchange, and quality data aggregation. I think the good news with all the money that's going to be going forward is that there are going to be many other organizations that are going to have our experience, and the bad news is that there are going to be many other organizations that are going to have our experience. So hopefully I can give some perspective on making sure that they don't have quite our experience with some of this stuff. So lest you think that I've taken multitasking to sort of an impolite extreme, I'm not doing emails. My notes are actually on here. So what I wanted to do is start with a couple of truisms, and they were actually just really reinforced by Michael and Bob. Where one is that that this stuff is hard, right? I mean, it's incredibly hard at the small practice level, and 2, EHRs don't spontaneously generate good data. Okay, and I think I don't have to go into the details of that. I loved Michael's stories. They could have described all of our physicians except with the only difference that our physicians are all part of Red Sox Nation, and each of them thinks that their EHR vendor is wicked bad. But it's the same exact stories. Embezzlement in particular. But getting past those truisms. I think one thing for us to recognize as we think about the way HITECH is structured is that 30 to 40% of retail EHR implementations fail today. And the way, just to get to the punchline here, the way that HITECH is structured right now is that the dollars flow right into that model of 30 to 40% failure. And so I said, to me, that there's some significant policy challenges that we face in trying to fix that fundamental flaw in the way that it's structured. And what do we mean by failure? Right? It doesn't mean EHRs ending up out on the sidewalk at garbage day. But I just give 2 examples. We're involved in a project in New York where they're applying now for the next round of funding. It's called HEAL 10. For the next round of funding, and they've done a survey of the physicians who would be in this particular grant application. 200 physicians, 50 of them are already live on EHRs.